Well, why don't we begin? Um, we are thrilled to have you all here. This is going to be, I think, a wonderful session for you. I'm Dave McCreary. I'm a Feinberg Major Gift Officer, and one of my responsibilities is to provide support for the Department of Preventive Medicine and its chair, Dr. Carnathon, who I am thrilled and pleased to be able to introduce this now. Um, Dr. Mercedes Carnathon, the Mary Harris Thompson Professor of Preventive Medicine, was named last year as chair of Feinberg's Department of Preventive Medicine. As such, she becomes only the seventh person to lead this internationally recognized department since its founding by Dr. Jeremiah Stamler. Dr. Carnathon has focused her research and career on the epidemiology of cardiovascular disease, obesity, diabetes, lung health, and cognitive aging. She does so by examining the significance of behavioral, social, and biological factors on chronic diseases in the United States and around the world. Her work also demonstrates how positive health and lifestyle behaviors, including diet, sleep, physical activity, can prevent the onset of disease and promote healthy lifestyles. Dr. Carnathon juggled the demands of being a scholar and track athlete as an undergraduate at Stanford University. After receiving her master's degree and PhD from the University of North Carolina at Chapel Hill, she returned to Stanford to complete a postdoctoral fellowship in cardiovascular epidemiology and prevention. From there, we are very fortunate she joined us here at Feinberg. Today, Dr. Carnathon will discuss critical windows, how life transitions shape women's obesity risk. Following her remarks, she'll entertain questions as time permits. Ladies and gentlemen, Dr. Mercedes Carnathon.
Thank you so very much. It is always a pleasure to work with you, David, and with the entire team. Uh, it is such a pleasure to be part of such a wonderful institution with such a strong network of alumni and collaborators. I'm really excited today to talk about an area of research that I have studied in some way or another and in collaboration with colleagues and collaborators, which is obesity in the population. And so today I'm going to talk about critical windows and how life transitions shape obesity risk. I see that I have the 15th on the slide. I'm apparently looking forward to the future. So, just to pose really an opening question, at age 25, Julie, a theoretical or illustrative individual, maintains an ideal weight effortlessly. At 35, Julie struggles with an extra 15 pounds that she's gained following her second pregnancy. And then Julie enters menopause and gains another 20 pounds. So, what's changed here besides the passage of time? And what I'd argue that is changing are really critical windows and our environment and how it shapes our ability to achieve and maintain weight over time. So, a brief outline of what I'd like to talk about today. Just a brief background on obesity, how we define it. Then to talk about the critical periods, the role of weight stigma, structural and social factors, and evidence based solutions. So I think I'll start with just a little more about me. As David described me, I'm a chronic disease epidemiologist. I started my career focused primarily and solely on cardiovascular disease epidemiology. Since that time, I have applied those skills and techniques to other chronic diseases, most notably lung health, which is really the third leading cause of death in the United States, or chronic lung diseases. And I do this using population-based studies. We design them, we recruit and enroll large groups of the population and ask them questions about their behaviors, their social history, their interpersonal relationships, their healthcare access. And we link those various risk factors with disease outcomes. And we do this in large populations so that we can study subgroups of the population. And I'm really fortunate to be able to do this at the Feinberg School of Medicine and leverage collaborations between preventive medicine and other departments to answer these critical questions. A central focus of what I'm going to talk about today is lifestyle and wellness, how our behaviors influence our disease outcomes. And more recently, I've become really interested in this concept of the 24-hour activity cycle, which is the balance and timing of behaviors across the 24-hour day and how those influence health, sleep quality, physical activity, and sedentary behavior, as well as diet timing and meals. And all of these are very relevant to cardiovascular diseases, very relevant to obesity and other chronic illnesses. And I do this in the context as well of what we do here in the Department of Preventive Medicine. When I had the pleasure of taking over in the fall, I was asked a number of big questions, which is, what is your department? What are you going to do with the department that has been outstanding for so many years? I've been in the department for 23 years, had been the vice chair for 10 years prior to this. And I was asked what some of my major initiatives are. And one of my major initiatives is that the research that we carry out within the department, that we disseminate that research. And that's because I see our faculty as scientific voices of truth so that we can bridge research findings and public understanding. And we do this in a few ways. One, by serving as conduits between complex scientific research that's published in our medical journals and public understanding. Um, During the most recent COVID-19 pandemic, I spent a lot of time with news stations, really helping people understand how behaviors and lifestyles were influencing COVID-19 risks. And during that, I realized how much was really needed as far as helping people to understand. And part of that is translating technical findings into accessible insights that ensure that accurate information prevails in an era of information overload. And relevant to the topic today, there's so much information out there around overweight and obesity because it matters so much for our overall health and wellness. So I'll start with talking about the burden of obesity in the United States, beginning with how we measure obesity. So body weight is comprised of bone, muscle, water weight, and fat. And the term obese is used to reflect the presence of excess fat tissue. However, we rarely have in population settings the ability to image fat and distinguish it from muscle and water weight and bone. And so we use what we call anthropometric measures, body mass index, which is a ratio of weight to height. And we use certain thresholds to reflect obesity. 30 being commonly used for obesity, normal weight falling between the body mass index of 18.5 and 24.9, and overweight as 24.9 to 30. So the limitations of body mass index is that it doesn't distinguish between weight from these various components and fat, and the accuracy of BMI varies with aging. It also doesn't tell us anything about body fat distribution or composition. One of the ways in which we estimate body fat distribution is by collecting some measurements or using imaging studies. So there's something called the apple shape, which is an android fat pattern you can see here on the left with the gentleman and the first lady. The apple shape is where more weight is above the waist, and we can measure that using waist circumference. Many men automatically know what their waist circumference is because men's pants are sold by waist and length. Women may not know that off the top of their heads, but we measure that in studies. And the other form is called the pear shape or a gynoid fat pattern, where there's more weight below the waist. We use non-invasive imaging to be able to measure the composition of fat within these regions and as well to look at the distribution. But in the context of population studies, we typically are relying on waist circumference. And later on in my talk, I'll talk about this shift, particularly among women, between the pear shape to the apple shape or android fat pattern that typically happens during the menopausal transition. So when we look at the prevalence of obesity, which is on the left, and severe obesity, body mass index greater than or equal to 35, we see a few different things. So focusing first on obesity, when we compare men, the first set of bars, to women, we see a roughly equal distribution. So this particular graphic is as well demonstrating changes in obesity or differences by age. 20 and older, which is the full age range of adults studied, is in the dark blue. We have a medium blue demonstrating 20 to 39-year-olds, where between men and women, rates are slightly higher among women as compared with men. When we get to the 40 to 59-year-old age range, they're fairly comparable as well, but slightly higher among women. And the same thing when we see those who are 60 and older. However, where we see notable differences are in severe obesity. You can see that across the age range, rates of severe obesity are about double in men as compared with women. That rate of difference is different in the 40 to 59-year-old, where it's maybe 50% higher. But you can see we go back to significantly more women in the oldest age group facing severe obesity. And this matters. And the reason this matters is because those individuals who are morbidly or severely obese are at markedly higher likelihood of developing cardiovascular disease mortality, which is the leading cause of death in the United States. I've had the pleasure of working with Dr. Sadia Khan, who's the Magerstadt Professor of Cardiovascular Epidemiology. She has a primary appointment in cardiology and a secondary in preventive medicine, where she started with us doing her postdoctoral research, focusing really on obesity and focusing on women's health across the life course. This particular graphic is represents the finding from a pooled analysis of around 10,000 people and we compared the rates, the lifetime risk of cardiovascular disease death by weight status. I'll call your attention to the normal weight in the light gray and the morbidly obese in the dark green. Across the life course, those women who were morbidly obese had 2.5 times higher likelihood of cardiovascular disease mortality as compared with those who are normal weight. And in addition to a higher risk of mortality, those individuals lived longer with a suite of chronic diseases, including arthritis, cardiovascular disease that hindered their quality of life, functional disabilities. And so higher rates of overweight and obesity are associated with all of those. And in fact, obesity is associated with a range of health outcomes: snoring and sleep apnea, lung diseases, liver diseases, various cancers, arthritis, blood clots, and gout, as well during the premenopausal years. Higher rates of obesity are associated with infertility, abnormal periods. So in fact, obesity affects almost every aspect of our health. So we talk about critical periods. So critical windows can be likened to a storm season, predictable times when conditions align for a change. Overweight and obesity is a complex condition that there's not a single cause, and thus there's not a single way to address it. There are psychological stressors or mental health stressors that can lead to changes in behavior and potentiate the development of overweight and obesity. There are hormonal shifts at the adolescent phase with pregnancy and childbirth and into the menopause that also influence obesity risks. There are structural barriers as well as social roles that influence the types of behaviors that one can engage in that would prevent or that would increase the risk of developing overweight and obesity. And all of these come together to that inform how weight changes over time and over the life course in women. So one of the critical things we often think about when we obviously consider women are hormonal changes. So I've overlaid this graphic of changes in estrogen and progestin across the life course. Puberty is when we see increases in both estrogen and progestin that remain very high during the reproductive years before falling during perimenopause and really leveling out at very low levels during the menopausal period. And we have along this timeline age. I'm going to talk today about 3 critical periods where overweight and obesity has some unique risk factors: puberty to early adulthood, the reproductive years, and the menopausal transition. So starting with puberty to early adulthood, there are dramatic increases in estrogen levels that prepare young ladies for reproduction. The increases in estrogen, as well as putting on body fat that is necessary to support the menstrual cycle. There are social pressures that influence body image during adolescence. And I received a really excellent question about um, eating disorders, and I'll address that separately in a few moments. But, um, there's a lot of information out there about social media and what it is telling our young girls about what they should look like, and the standards that social media is putting out there for what people should look like. There are also rites of passage, including leaving home for college, starting professional work that influences individual lifestyle behaviors in the environment. Just personally, I recall when I went to college, one of the things my parents got me was a bike so I could get around the very big campus of Stanford University. So every day I was leaving, I was taking a bicycle. I was also running track. So I was doing all of this physical activity. Well, when all of that ended and I was sitting in my office and desk where I am now, I had to be a lot more intentional about physical activity in order to maintain my weight at a healthy level. And this is really important because weight patterns that are established in adolescence and early adulthood persist into middle age. I am currently one of the leaders of a study called the CARDIA study, the Coronary Artery Risk Development in Young Adult study. It was formed in 1985, 1986, when these participants were ages 18 to 30. And we have followed them now for over 35 years. We're preparing now for our 40-year follow-up examination. And these data come from a paper that I participated in that was published back in 2016, looking at 25-year weight changes. In the dark orange, we have white women, and in the dark green, we have Black women. And this is weight alone, not body mass index, which is why the women are much lower than where you see the men's levels. And what we see are larger weight gains earlier in women that tended to level off over time. And in this case, some of these women were entering into menopause by the time we stopped this study. But if I were to show you updated data, we see something similar with continued creep upward. One of the unique features of the Cardia study is that it started in 1985 before the onset of the current obesity epidemic. And so the baseline weight of these women and the body mass index is a lot lower than what we would see in a contemporary cohort right now of 18 to 30-year-olds. These patterns of lifestyle behaviors that are associated with weight are actually established during childhood and adolescence. So if we really want to understand more about these changes, we need long-term cohort studies that start when people are a lot younger. And these steady increases in weight continued in cardio with few exceptions. One thing we'll see in our data, suddenly people's weight will fall. Well, it turns out they've had bariatric surgery, or they've taken on medications, or they're sick and they've lost weight. Rarely do we see changes in reporting of the primary behaviors, diet, physical activity, even sleep, that influence weight change to an extent that we would see a marked and persistent change in their weight. So our weight as a population is going up and up over time. So a question that was sent in advance is, what's the earliest age for recommending Ozempic, which is a GLP-1 or glucagon-like peptide-1 agonist? And it depends on the indication for using it, but children as young as 10 years old can use it for diabetes management. Sorry, I said prevention, but management when you have diabetes. And children as young as 12-year-olds can use certain types of GLP-1 agonists for weight management. So physicians can prescribe these fairly early on. This typically is going to be a medication that one would use throughout the life course. And what about eating disorders? Eating disorders do remain a significant health concern, particularly among adolescent girls and young women. I don't know what the solution to that is. I do think that the social media culture is negatively influencing body image in young girls. I think I've seen a lot more in the fat acceptance movement. It's labeled fat acceptance, but I think it's healthy at any weight. I think it's celebrating what our bodies can do for us and embracing healthy lifestyles at any weight, and that's what matters. So the reproductive years, here's another illustrative case study. Sarah gained 40 pounds during her first pregnancy, which is a little bit outside the recommended weight gain for somebody starting a pregnancy normal weight. Within 12 months, she lost 25 of those pounds And then in her second pregnancy, she gained 35 pounds, and within 18 months, she had lost 15 pounds. Where that leaves her is a net weight gain of 35 pounds between ages 25 and 50. So, the correlates of weight gain during the reproductive years are certainly the biological needs. The body is designed to store energy to support fetal development. But on average, women are retaining 2 to 5 pounds after each pregnancy. And this has a compounding effect across multiple pregnancies. And it's even more severe when the interpregnancy interval is even shorter, so giving less time to be able to lose weight. But beyond the biology, having a newborn can inform sleep disruption. And sleep disruption and sleep restriction are associated with weight gain, changes in insulin metabolism, which can promote further weight and the development of metabolic disorders, including diabetes and hypertension. There are various psychological stressors around childcare and roles that change when one becomes a mother, as well as practical barriers. Where do you take your child if you wanted to go be physically active? And then changing social roles and identity. I had a parent say to me when I was at a birthday party when our children were younger that once they had children, their intake of pizza went up by 200%, because at the end of every birthday party where pizza is served, the host tries to give away the pizza to everyone, and as busy, hungry parents, we just eat the pizza and keep on moving. So I can certainly say that there are a lot of environmental factors around having children that do lead to possibly less healthy changes in one's diet. There's also a risk of this intergenerational transmission of obesity. So when a woman retains weight and enters into the next pregnancy overweight or obese, there's this feedback loop. When you see excess gestational weight gain, some individuals are going to develop gestational diabetes or postpartum weight retention, which can then lead to hypertension, diabetes, and cardiovascular disease. But pre-pregnancy obesity also can lead to altered fetal growth and metabolism. So fat mass of the babies can be larger. They have altered satiety or fullness mechanisms, which over time can lead them to then become obese. So when we see these pictures of overweight or obese parents whose children are also overweight and obese, some of it is certainly informed by the environment that they're in and lifestyle choices and modeling within a family unit, but some of it may have been pre-programmed when they were pregnancy if they entered into that pregnancy overweight or obese. One of the studies that we are working on trying to get funded, and we did a pilot study, is the activity measurement and postpartum mothers study. So what we were interested in is that sleep, physical activity, sedentary behavior, and diet are the behaviors that are most strongly associated with body weight. And what we want to do is determine which behaviors uh, are the most strongly associated with postpartum weight loss, when during the day and over the course of the 12 months post-pregnancy these behaviors have the greatest influence, and in whom do these behaviors have the largest impact on postpartum weight retention. One of the questions that drove this for me is quite frequently women will ask, is it better for me to nap when the baby naps, or should I go be physically active? Well, those are a couple of choices when you have what we call time poverty. You have a few choices and very little time to make a decision. Should you do this? When should you do this? So we know that there are circadian rhythms to every behavior and every body cycle. Engaging in physical activity right before bedtime is going to be disruptive to sleep, just like eating right before bedtime is going to be disruptive to sleep. But there could be different combinations so that we can come up with personalized plans for weight loss in the 12 months postpartum that could be tailored to different populations of women, women who have other household members, such as other children in the house that they have to care for, or a partner who could support them if they wanted to leave to be physically active, women who are working versus those who aren't. Those women who've got infants who, like mine, woke up every 40 minutes or maybe the first 13 months. So there's a lot of sleep disruption there. Women with social adversity. It's one thing to go for a walk during the summer with a stroller, but it's a whole nother thing if you don't have the money to afford a gym to work out here in the city of Chicago to expect someone to be able to be physically active year round. So this is something that we have submitted to the NIH to get funding, and we're seeking some other foundation funds as well to try to support this line of research. And we're doing this, sorry, I didn't see this point, by recruiting women 4 months postpartum and measuring their behaviors and weight 3 times over 8 months. So, how do you safely take care of yourself and lose weight during periods when you're caring for your kids, parents, and friends? There's really no easy answer on this one other than to prioritize maintaining a healthy lifestyle, not specifically for weight loss, but for overall health and wellness. As women, when we prioritize our own health and wellness, we're better able to care for those who we care about and as well model what it means to be healthy and strong to those you care about because a healthy lifestyle is for everyone. So it has to be a priority. So now we talk about the menopausal transition. The menopausal transition is associated with a great number of cardiometabolic changes, changes in body weight, lipid metabolism, vascular dysfunction, so raising the rates of cardiovascular disease in this population, vasomotor symptoms, quite frequently we hear about hot flashes, sleep quality, insomnia is more common, sleep fragmentation, which then influences sleep quality overall. And then psychological and cognitive health, talking about brain fog. On average in the population, women are gaining 1 to 2 pounds per year. The perimenopausal period can last 4 to 8 years. And so overall, you can see this can be a fair amount of weight gain if left unchecked. Body composition also changes and in ways that enhances cardiovascular disease risks. There's a shift from the gynoid or pear shape to the android, and muscle mass declines 1 to 2% per year. But as well, these other menopausal symptoms, poor sleep, psychological, vasomotor symptoms, can contribute to adverse weight gain by leaving people unmotivated, not feeling good, not wanting to engage in these health behaviors. Um, Recently, a colleague who I had worked with the American Heart Association joined our faculty in preventive medicine, and that's Deepika Laddu. And Deepika did a really nice series of papers that are showing changes in physical function during menopause, muscle strength going down as measured by hand grip in this first phrase in this first graphic here at the top. Walking speed is also declining during the menopausal transition, as well as chair stands. And we focus on physical function because Deepika is a nutritionist whose primary area of research has actually been in physical activity and strength training. And so she was highlighting these changes to highlight the potential for strength training, which was a question that was brought up. A few questions. How does one lose abdominal weight during the menopause? Does enhanced protein intake help? Now, I happen to be on social media primarily to track my children's sporting leagues and their school, and somehow it figured out what age I might approximately be, and I'm fed a bunch through the algorithm about menopause. And I see that high protein foods and strength training appears to be quite a fad and very important right now. And there is some science to back that. So high protein foods are more filling than carbohydrates and fat. Diets that are 25 to 30% protein can lead to greater weight loss and better weight maintenance, in part because the body has to burn more calories digesting protein than those other simple sugars. So carbohydrates break down pretty quickly into simple sugars. That's why we promote them for the use of energy during endurance events. But proteins take a little longer and a lot more effort. And 1 to 2 grams per kilogram of body weight of protein is recommended during the menopausal transition in order to support healthy weight maintenance at a lower level. What is the evidence about strength training to combat menopausal changes in body composition? When coupled with high protein diets, you can combat the aging associated loss of muscle mass to preserve muscle mass. And you want more muscle mass. Muscle weighs more than fat. And so if you're looking solely at BMI, you might not see changes in BMI, but muscle also burns many more calories than does fat tissue. So you want to have that muscle. Not only is it healthier for you metabolically, but it protects your physical functioning, which informs your independence during aging. So strength training can be particularly important. And does social support during menopause help manage symptoms? I think resoundingly yes. Adequate social support, both the emotional support, recognizing what one is going through, as well as practical and logistic support, can help women find more time to care for themselves, helps with stress reduction, and provides purpose and meaning to make and stick with changes. Making behavior changes is hard. That's why people want a quick fix. They want a medication. And we may have some medications that can be very helpful, but those medications do have some side effects, particularly GLP-1s. You lose a lot of muscle mass as well as fat mass. And so that is where circling back around to the importance of strength training and adequate protein intake is particularly important to stay healthy during the menopausal transition. So, looking at weight stigma, when I pulled these data looking at deaths by risk factor in the United States, sorry, around the world, you can see that within our top seven obesity falls, 3.71 million deaths around the world are attributed to obesity. You can see certainly some other behaviors even higher, such as cigarette smoking. How would we manage the other risk factors on this list? Some diseases are blameless, whereas others are seen as someone's fault or a personal failing. Where do you think obesity falls? And that is really meant as quite a leading question. Weight stigma is very real. Society has historically treated obesity as a failure of willpower rather than as a disease. There are biases by healthcare providers about persons with obesity not having the willpower or the strength to make recommended behavior changes. There are biases by employers, often referring to and known to refer to individuals as obese. You hear rumors about laziness or lack of commitment or focus. And in the end, individuals with overweight and obesity have constraints in their lifelong earnings. And this shame can be internalized by persons who have obesity. And I highlight persons with obesity, and I probably have spoken incorrectly throughout the rest of the presentation. Some time ago, we certainly made the shift to referring to individuals with a disease not by their disease. So we don't call them diabetic, we call them persons with diabetes. But these same shifts have been harder and slower for something such as obesity. And even I likely made mistakes early on in my talk by referring to obesity or obese people rather than persons who have obesity. Weight stigma can compound during critical periods. Adolescent girls see rapid changes in weight that, even with the same behaviors, they'll see their body fat go up because that is natural and healthy. But this can affect their self esteem. It can also affect their social position. There are judgments about weight gain during pregnancy. I mean, the number of comments that people mistakenly make when somebody is overweight or obese. Well, go for it, you're eating for two, or even sly comments such as, wow, are you eating for three? Those things really do affect women who are pregnant. And then there's the pressure to bounce back when you're postpartum. And that pressure can start pretty early, even while somebody is still nursing, still tired, or experiencing a lot of psychological stress from role changes in being a mother. And then there's the narrative that, women who are menopausal just let themselves go because it no longer matters anymore. If women are no longer sex symbols, does it matter if they have a belly? Well, in fact, it does for their health. It as well does for their self-esteem. And then the impact on health. The stress and isolation from stigma can lead individuals with obesity to not want to ask for help for fear of what they're going to hear, including shameful comments about just change your behavior. And without effective management tools, metabolic health can continue to worsen over time and have physical and mental health consequences. So these are critically important factors in managing overweight and obesity. And the media has always been involved. In the 1940s, try bile beans to be fit and slim. These headlines continue. America's obesity epidemic, especially among women, is expected to get worse, with particular populations highlighted as being the most vulnerable. And, where is this plus size revolution we were promised? So, for a while, there certainly was a push for improving how we treat individuals with obesity. But, despite a booming demand, there's still a lot of fat phobia and neglect. And then there's entertainment. I note that tomorrow a Netflix special is coming out about the abuses that went on The Biggest Loser, that television show that had people competing for weight loss. And then, there's really a lot of harmful effects of fat shaming. There are entire articles and meta analyses done showing that fat shaming leads to psychological distress and is not a motivator for weight loss and that can do real harm. And really ignoring the systemic and structural factors that inform individual choice and behavior really continues to inform the problem even further. And so that's where I'll talk about some of the structural factors. So there's geographic patterning of social vulnerability and obesity. And this is a map of Chicago. On the left side in the blue, with the darker blue, is where we see the highest rates of obesity in the population in those dark patterned areas. Well, if you look on the right by social vulnerability, with higher levels of vulnerability reflecting darker colors, you can see that the south sides and the west sides of the city, these are individuals with fewer socioeconomic resources as well as higher rates of obesity. And I could generate a slide of obesity that shows the same patterns: diabetes, heart disease, lung disease, even cognitive dysfunction and dementias. And that's because the neighborhood environment presents multi-level risk factors for obesity. We have individual characteristics such as stress, wealth, and well-being in the smallest circle. Of course, my light goes out, but hopefully you can still see me. We have the interpersonal environment, the relationships, social networks, household relationships, clinician relationships, how one's neighborhood provides access to healthy foods and safe spaces for physical activity, institutional policies and how those inform, and the historical context, particularly when we see marked disparities in overweight and obesity based on race, ethnicity, and socioeconomic positioning. These environmental factors matter and they inform individual choices. One of my colleagues, let me move so I can get a little bit of light in here. And at least that broke up my sedentary time a little bit so that I'm not sitting for the full hour. One colleague, Dr. Chiari Kershaw, who is a professor of preventive medicine, has done a lot of work on various characteristics of the neighborhood environment and how they inform weight-related risks. One of the characteristics that she studies is racial residential segregation, showing that individuals who live in racially segregated neighborhoods have higher likelihood of obesity, hypertension, and cardiovascular disease. In this particular study, a junior colleague of ours who Chiari was mentoring, Lindsay Poole, did a study showing how changes in residential segregation over time are related to the development of obesity. Those women who stayed in segregated neighborhoods for longer periods of time were significantly more likely to become obese over time in the Cardia study. There was no association among men. And so Chiari's done a couple of these different studies, and we regularly see this finding that the neighborhood tends to have a stronger influence on women as compared with men. And we don't know why that is. And it's something that we certainly are exploring and that she is doing in her research. But the most important thing that she says when people ask her about the role of the neighborhood is, should we move people or should we change the environments to promote health and wellness? And the answer is fairly obvious. We need to change the environments to promote health and wellness for all. And now we think about evidence-based solutions. So much attention right now is focused on pharmacologic management. Lifestyle change we know works. We know that surgery works, bariatric surgery. But once the investigation of GLP-1 agonists in particular expanded beyond their original use for diabetes, we found that over half of US adults are eligible for the use of GLP-1 agonists specifically for weight loss. And that's because the rates of overweight and obesity combined in the population exceed 70% and tend to go up over time. So satiety may now come in a needle, and there are multiple benefits for the drugs for GLP-1 agonists. When I was in Los Angeles, I saw this sign. And it was fascinating to me because I don't see signs advertising Ozempic in the Chicago area, yet I saw them in Los Angeles and thought to myself that the cultures there may be very different, but these are being widely marketed. It would be wonderful if everybody could have them, but we have something called the Friedman's Health Impact Pyramid, which is that those factors at the base of the pyramid are interventions that would have the broadest impact on the population, whereas those at the top of the pyramid are those that require the greatest individual effort. And you can see clinical interventions, of which GLP-1 agonists would fall under, closer to the top of the pyramid. It requires someone to have the time and the availability and the financial resources to be able to use those particular therapies. And what we learned when we did this review paper, this was led by Deepika Laddu, the implementation of obesity science into clinical practice, we have evidence-based therapies that exist and that work. However, there are significant barriers in access to the most effective therapies, particularly for those who have the greatest needs. We see that bariatric surgery rates are much lower in those with lower socioeconomic position, as well as those who don't have the social support. And the same can be said of GLP-1 agonists, which can cost for some out of pocket $700 to $1,000 a month. Obesity interventions are needed to target multiple levels of influence using a diversity of strategy. Policies that restrict access and create and reduce obesogenic environments, things that bring grocery stores to neighborhoods that are underserved, can provide access to healthier foods. Financial reimbursements and supports for lifestyle change are needed. Being able to provide workplace access to physical activity, safe spaces, or healthy foods at reduced costs can reach a large proportion of the population. Certainly, the same can be said of youth. Intervening to make school environments healthy and to teach and educate around obesity prevention. And then finally, the social support to be able to address obesity. A few years ago, I think it was last year, I had an opportunity to participate in a debate at the European Society of Preventive Cardiology. And that debate question was, which is more important for cardiovascular prevention, losing weight or improving fitness? So caloric reduction is associated with weight loss, whereas physical activity enhances fitness and muscle strength for improved weight maintenance and physical functioning. And they have effects in similar mechanisms. Decreased body weight and increased fitness can improve metabolic risk factors. Muscle strength and quality can lower inflammation, improve endothelial function, autonomic function, psychological health, quality of life, and sleep. Quite frequently, physical activity is cited as a exercise as medicine. It is one pill that can do many things. Losing weight as well can lead to improvements in multiple systems. Well, there's a whole line of research, and my answer in the debate was yes, and that's that being normal weight isn't sufficient protection against CVD. So there's an entire area called the fit fat hypothesis that was spearheaded initially by Stephen Blair, who passed away recently. He was a faculty member at the University of South Carolina. So if we look at the leftmost panel as an example, we have on the left side a blue circle and red triangle reflecting healthy BMI. And on the right side, we have the same in individuals who are overweight or obese. So I drew a dashed line to divide them. And what we see is that even among those who are normal weight, so looking at the left, if they are unfit, they had a slightly higher likelihood of all-cause mortality. And you can see this when we look at body fat percentage, the left panel, the one in the middle. You can see this with healthy waist circumference, that there's still an elevated risk among those who are unfit. And for those who have non-optimal body composition, being fit, the blue circle, is associated with a lower likelihood of mortality. And so I think this really underscores the healthy outcomes at any weight, if we can engage in healthy lifestyle behaviors, can be particularly important. And focusing on engaging in behaviors to improve fitness can be empowering for all individuals who are struggling to maintain weight without pharmacological or surgical interventions. And so one of the questions was, can GLP-1s be used to reduce obesity risk during these phase of life transitions? And are GLP-1s an option for aging women who are not obese but overweight to be used as an adjunct to lifestyle modifications? So right now, GLP-1s are not typically used as prevention strategies, but are used once disease is established, disease being overweight or obesity. But I found this really wonderful review that looked at 175 health outcomes. And it reported that as compared with usual care, GLP-1s were associated with a reduced risk of substance use and psychotic disorders, seizures, neurocognitive disorders, coagulation or blood clotting disorders, cardiometabolic disorders, infectious illnesses, and several respiratory conditions. The reason why GLP-1s are so broad is we consider them as having a pleiotropic effect. And we don't necessarily know all the ways in which it can improve all of these health outcomes. But it does appear to have an effect on the brain, given that it improves substance use and psychiatric disorders as well. It can reduce food cravings, which can change eating behaviors in individuals. And it could be that secondary to weight loss, these many other things also improve. As one who is struggling with osteoarthritis in my aging joints, I thought to myself, I wonder whether there's research on the application of GLP-1s to address um, osteoarthritis, particularly if overweight, specifically if overweight and obesity isn't the primary driver. And there certainly is a call for research in that very area. And so I've started some discussions with individuals in the orthopedic surgery department and doing outcomes research, because one of the benefits of being an epidemiologist is that I have a bag of tools to be able to address a number of different health outcomes, and I can explore and even conduct me search at times. So thinking forward to the future, obesity is a highly stigmatized condition which influences how persons with obesity are treated in society. It is a complex disease that arises from a combination of genetic, behavioral, and environmental factors. And these factors and their influence vary between females and males. They also vary within individuals uh, amongst women. You're going to see some individuals eat the same things but see very different outcomes. There is no single approach that's going to work to prevent obesity or to treat it. We need a better understanding of obesity in unique populations and across life stages, as well as tailored strategies that account for an individual's circumstances and context in order to promote health and wellness. So I wanted to make sure to leave a little time for some questions that have come up that I haven't already addressed. So thank you very much for listening. Sorry about the disruption of hopping up.
Thank you, Dr. Carnathan. Definitely much insight and thought-provoking information you shared with us. So we're grateful. Um, I'm back to host some of your questions. We've got some that were sent in early, and Mercedes did an awesome job of addressing many of them. And we've had some that have been submitted live. I want to start before we dive into the specific ones on obesity with a little broader question. Can you share with people what some other research projects are that are priorities in the Department of Preventive Medicine that relate to women's health?
Yeah, absolutely. Thank you so much for asking that. In recent years, we have had a growing portfolio of research that's focused on women's health within the department. And we're really enthusiastic about this because this research covers a broad domain of health outcomes. Quite frequently, when people think about women's health, they think about reproductive factors, and that feels as though it's the purview of obstetrics and gynecology. But we have looked at how reproductive factors, including adverse pregnancy outcomes, are related to long-term chronic disease risks. That's been a significant focus. We are also looking at breast cancer survivors. So Siobhan Phillips does a lot of lifestyle interventions in women who have survived cancer to see how these lifestyle interventions influence the risk of cancer recurrence as well as quality of life over time. As well, with the introduction of Deepika to the department last year, who does a lot of work in the Women's Health Initiative and in aging women, we've expanded to look at physical functioning in women as well as dementia risks. Both Deepika and Kiari Kershaw and myself have done a lot of work in cognition. We really have a breadth of research on women's health topics and outcomes that involves not just people in our department, but collaborations with obstetrics and gynecology, medicine, and pediatrics.
Great, thank you.
Mhm.
We had a question, getting back specifically to obesity, about how to take care of yourself and lose weight when you're a caregiver, for
Yeah.
kids, for parents, for friends, for
Mhm.
elderly. Can you comment on that?
Yeah, it's very, I brought that up a little bit, and it can be very hard to find the time to prioritize yourself when you're caring for someone else. And I think this is a place where social policies that would provide respite care at times, if somebody does not have social support within the home, to be able to allow those breaks. You end up with sleep disruption, providing 24-hour care for aging individuals, for younger children. Sleep disruption can be a significant problem. Finding the time to exercise, or even grocery shopping when you're having to feed someone a special diet and you yourself need to also eat a healthy diet. I think prioritization and opening up to be able to share resources and social support with others who are caregivers is a good strategy to be able to carve out that time for personal health promotion.
Thank you. Specific question, how does obesity affect secondary infertility? Meaning trying to conceive after giving birth and weight gain from the previous pregnancies.
That's a really good question. Certainly, obesity is associated with primary infertility. And if it is, I could imagine that if there were significant changes in weight following the first pregnancy, it may cause additional challenges. I am not ideally suited to speak to the specific mechanisms by which overweight and obesity can influence the ability to become pregnant and remain pregnant. I think that there is a lot of work in this area, particularly as women are starting um, their reproductive journeys a little bit later or at an older age than before. So I think there are just a number of factors that can influence those outcomes.
Um, you touched on some of this, but it's still a good thing, I think, to revisit. What should someone do who really doesn't want to take drugs for the rest of her life, who
Yeah.
really doesn't want surgery? Is it possible to achieve sustained weight loss after menopause?
It is very challenging. Lifestyle behavior works. However, the effect to which it works and its strength of association can be so heavily governed by genetics as well that it can be a real challenge. The focus in the postmenopausal phase needs to be on maintaining a healthy body composition and healthy food intake. One of the things that can happen with aging is sarcopenia, which is the aging related loss of muscle function. When that loss of muscle function exceeds the average that we would expect to see, we can end up with something called sarcopenic obesity, which is that your body mass index could look lighter or about the same, but the amount of fat can be much higher, which is metabolically unhealthy. And so it's particularly important to maintain the lifestyle behaviors. That is where a focus on strength training, those are the sort of trials that Deepika Laddu is doing, is strength training to prevent the development of hypertension in older adulthood. Um, that's where those sort of behavior changes can be particularly important. I certainly don't think that the use of GLP-1s in older adults needs to be necessarily the first line therapy unless we're talking about severe obesity. And again, I'm not a physician, I don't prescribe things, but what we see in the data and what our experience has been as more and more individuals have used these GLP-1 agonists is that you would lose weight, but you would lose both muscle and fat. When you go off of the GLP-1 agonist, what tends to be gained back is fat, because at that age, that's what tends to come back more so than muscle. And so a decreased emphasis on overall body weight but much more of a focus on healthy lifestyle in older adulthood is going to be critical for healthy longevity and independence.
You were just talking about strength training, and there's a question
Mhm.
here about from someone who said, I exercised 2 hours per week for 6 years and initially lost 30 pounds. After that, nothing. I'm 66 now. Why did this take place? And I do note it does say exercised past tense. So maybe current
Yeah,
tense would help.
you know, that's an interesting question. As one ages, the metabolic response to the same behaviors changes. At if that had started at age 60, one was already postmenopausal, and so the most rapid changes in weight gain tend to happen during the perimenopausal period. What can happen during the postmenopausal period is things do tend to level out, but with continued declines in muscle. It would be important to continue the exercise to maintain the strength and balance in order to ensure physical function does not also change markedly. Whereas the scale may not be changing, what could be happening is a preservation of bone density, a preservation of muscle. The body fights to keep itself at a given weight. When you increase exercise and increase calories out, what the body does is it actually gradually slows down your metabolism so that it can conserve its body weight. The body is very committed to maintaining homeostasis. And so, what one has to do to continue weight changes is really mess with this a lot and in different ways. And so, you'll see weight losses, then you'll see plateaus where you have to make even more extreme changes to the caloric balance by either restricting calories further or raising physical activity in order to trick the body and move it out of this homeostasis. However, that may not be necessary if the body composition is good, if metabolic risk factors are good. It may just be a new set point, and it's encouraging and positive to keep a stable weight at a certain age.
Um, quick question, follow up to that. Is changing around strength training versus aerobic, and does that make an impact at all?
Aerobic training is also very important. So aerobic training calls on a different body system for energy. It's pulling carbohydrates. Strength training is building muscle strength. So if you're engaging solely in strength training, you may not see overall changes in body fat or weight, but you'll see more strength, which also can have more benefits metabolically for the prevention of various cardiovascular diseases. The most attention right now, I think strength training has been very popular. We are also in the research field trying to find better ways to study it and capture it.
Well, we want to stay on schedule for everybody. We promise an hour, close at 1. It's 1 o'clock. I want to thank everyone, but in closing, I would like to say that Dr. Carnathon, you shared with us fabulous information, very thought-provoking, very insightful. We're grateful for that. And I can make sure everyone knows that what Dr. Carnathon does, her colleagues do, the Department of Preventive Medicine at Feinberg is doing fabulous work. And please, if you have a chance to provide support for it, they need it and they'll do more work with it. So thank you all and have a wonderful afternoon.
Thank you so much for the opportunity.